the same time, it's important to think because it is something that is often needed with patients. And there was this kind of flip in my brain at some point where instead of looking at this as an ablative procedure, it is no longer an ablative procedure in my mind. Again, for the ischemic patients, they have to get rid of the dead tissue. That's very important. But on the other side of it is once you get rid of whatever you need to get rid of, the patient's rest of their lives and hopefully will be able to do everything. It keeps going by itself. So when I started thinking about an amputation as a reconstructive procedure and a way of being able to create more function in something that wasn't there before, that was kind of an aha moment for me. And at the same time, that's something I can bring along to patients who, the minute they hear amputation, their face drops and they can't see the rest of their life. So talking about it in those terms, thinking about it in those terms for all of us, I think is really important. Surgical goals of amputations are listed here. And my partners are going to be talking more about this, so I can kind of skip this. We all kind of, Dr. Kanan is going to talk a little bit about history too, but 31,000 years ago, they found a grave where the lower leg was separated from the rest of the body, and it was clearly done in a surgical way. And so this was 31,000 years ago that they found this. They also in ancient Egypt, in the tombs of the pharaohs, they found prosthetic toes, so clearly they had been taken off, maybe for gout, who knows. Around 2000 BC, an Indian poem where a warrior queen lost her leg in battle and then had an iron leg put on and then came back. And then some coming closer to our modern age, when already 2,500 years ago they were working with tourniquet and surgical drains and cautery. So I think I'm going to pass it over now to Dr. Shachar Kanan. He is an amazingly trained orthopedic oncologist who has been working with Northwell for about 5 years now, and talk about lower limb. Thank you.
Thanks, Dr. Goodman. So yeah, I'm Shachar Kanan, one of the musculoskeletal oncologists, and it's a big topic that I'll try to get through. I'll be focusing on amputations of the lower limb. Happy Sarcoma Awareness Month to everyone. And if you can't hear me, please let me know. Let's see. So I have no disclosures other than the fact that I'm a dad. And so you're going to see these corny jokes throughout the presentation. And it's just, I can't help myself. But, we got to take this in stride. And that's how we perform a successful amputation. We have to be optimistic. And that really is the key to a successful surgery. Both the surgeon and the patient needs to be motivated. You need motivation. You need optimism. We, as the care providers, need to express to the patients that an amputation is not considered, it should not be considered a life-ending procedure, but rather a life-saving procedure, especially when you're dealing with sarcomas. It could be a curative procedure. We want to take a patient out of the attitude of the picture on the left and into the attitude of the picture on the right. And this is a radical procedure that I would never recommend for anyone. And as this reviewer only gave 1 star to the operation, will say it was terrible and would not recommend. But when it is a last resort and we have no choice, this is a curative procedure that can really help a patient. According to this T-shirt that I found, the ingredients to success are 100% motivation, hustle, heart, and passion. These are all very important to have for the patient and, again, for the surgeon to get you through this. Our goal is not only to get a patient to get back to their ADLs, activities of daily living. We want them to be fighters. We want them to be runners. We want them to get back and be and go to the Olympics like Oscar Pistorius, as we all know. What we don't want is for them to end up on the front cover of the New York Post after murdering their wives. That's definitely not something that we would want. So as far as our agenda, we'll be talking about epidemiology. There are about 2 million amputees in the United States. Most of them are either vascular or trauma related. Only 2% are cancer related. And this is where Dr. Nolan, myself, and Dr. Goodman are focused on. So this is not a routine procedure for us. We are not doing amputations every week. This is a last resort. We are interested in limb salvage if possible, but when we have no other choice, we do perform the amputation. Some of the history, like Dr. Goodman mentioned, we can even go as far back as 1700 BC in the Babylonian Code of Hammurabi. We all know the saying, an eye for an eye and a limb for a limb. And again, Plato and Hippocrates discussed this as well. Back before anesthesia, this procedure was very difficult and crude. Patients were awake. They'd be given alcohol, and their stumps would be dipped in boiling oil to try to get hemostasis, and you had a very high mortality rate. I'm not going to go into detail about the history here, but you can see the first successful above-knee amputation, 1588. Hip joint amputation was in the 1800s. And then there's a procedure called the Erdl in 1920 that I'll talk about, where you take the end of the fibula and you try to create a kind of an osseous bridge from the fibula to the tibia. I'll talk about all of those. No talk on amputation is complete without discussing this case. I don't know how many here know about this case. This actually happened. This is Robert Liston, Dr. Robert Liston, who was a famous surgeon. Back then, without anesthesia, you had to perform these procedures extremely quickly. He performed an amputation in 28 seconds. But this one took him a little bit longer. This amputation took him 2.5 minutes. In his fury and rage, as he's cutting the leg off, he actually cut his assistant's fingers off. That assistant later went on to develop gangrene and died. The patient who had the amputation also developed gangrene and died. And in addition, there was a spectator that was witnessing the event who also collapsed and died, maybe from a heart attack. So you actually had the only case in medical history with actually a 300% mortality rate. Again, we're going to be talking about the non-ischemic amputations, but these are some of the indications for amputation. Our equipment includes a blade. This, I would say, kind of first-gen equipment. All you need is a 10 blade, and that's all you need to cut it off. But we got better. This is a second-gen equipment, a bovie, and a tonsil, and you can do anything you want in orthopedics. But I think the third gen is this, the ligature. Many of us use it. I think it provides a much cleaner cut on the soft tissues, and I think it really helps promote the healing of the soft tissues. It takes a lot longer to do, but I think it's worth using. This is the way I do it. So many levels of amputation in the lower limb. We could talk about hemipelvectomies, which involve the pelvis, hip disarticulation, and transfemoral amputation, also known as AKA, to below-knee amputations and various amputations of the foot. Depending on where you perform the amputation, you could do it at the level of the toes, the level of the transmetatarsal, the Lisfranc joint, Chopart or Syme amputation. This is a Syme amputation. You are performing an osteotomy through the distal tibia and fibula, making a clean cut, removing the rest of the bone, and then you have a nice heel. That's a very solid heel stump that you flap over. But these patients often get some migration of that stump, and that's one of the issues with this amputation. The Boyd amputation tries to solve that problem, and you're actually keeping some of the bone. You're keeping the calcaneus, you're removing the talus, you connect the calcaneus to the tib fib and try to make a fusion. But you do have high rates of non-union, so it's not often done. Where are we going to amputate? So this is a balance that we have to strike. We want to increase the function of a patient by performing a more distal amputation, but at the same time, we want to decrease the complications and have an improved oncologic margin by going more proximally. As the amputation goes more proximally, the walking speed decreases and oxygen consumption increases. This is a commonly tested subject for our in-training in orthopedics. I don't know in physiatry if they also are tested on this, but based on the level of amputation, you're requiring more and more energy. A long transtibial, that means very distal, is about 10% above energy baseline. You get to a short transtibial, 40% above baseline. Actually, bilateral BKA, which is below-knee amputations, are 40%. It's not much different from a single below-knee amputation. But as soon as you go above the knee, transfemoral, you're looking at 75% above energy baseline and decreased speed. This is different when you're looking at the PEDS population. In the PEDS population, as long as you go from the knee and below, you actually maintain the same speed and same energy consumption. That's also a commonly tested question. But the focus of my talk is going to be on above knee amputations and below knee. And I'll be talking about this knee and I'll be talking about that knee. So the amputation, as far as the below knee, can be at different levels. If you go too high, you are going above the tubercle, and that's going to be a functionless BKA. So you're trying to get a good level of resection while you're still achieving a good function. You need about 12 centimeter from the joint line. Different ways of closing it. You can do a fish mouth, as in the picture above, or in the below picture, which is a skewed flap. That's my preferred way of doing it. I like the soft tissue coverage that you get with that. Here's a picture of that type of closure. It is a much more technically difficult procedure to do. You need to find these 5 nerves and those 3 vascular bundles, ligate them sharply, and we'll be talking about TMR and other things. But so it's not as easy as an above knee amputation. This is the Erdl that I mentioned, described in 1920. You can see different ways of doing it in that figure. Figure A, you have the distal fibula that is connected with sutures, just heavy sutures. Eventually, it forms that osseous bridge. B is a screw, and C is actually a Arthrex tightrope. If you can look closely, you can see that tightrope there. Supposedly, you get a more closed environment of the bone, and it's better for soft tissue healing. But in reality, it's not really proven in any research yet, but many people do it this way. And this is the procedure. This is what the below knee prosthesis looks like. I'm sure we'll be talking about it later. Now, above knee amputation, you want to, again, maximize the lever arm as best as possible. But if you leave too much bone, it's going to be a lot more difficult for the orthotist to create a prosthesis where you match the joint line of the knee. So the ideal resection is about 12 centimeters from the joint line. Commonly asked question on our in training is this adductor myodesis to help prevent an abduction contracture of the limb. Again, you can do a fish mouth. I prefer a flap. Actually, what I do is I bring the anterior flap posteriorly. I'll show a picture of that later. And this is what the prosthesis looks like. I have to talk about rotation plasty, given that this is a lower extremity amputation talk. This is, imagine, it's very confusing, but imagine you had a tumor in the knee. Otherwise, the hip and the ankle are totally normal. If you can somehow remove the knee and bring the ankle, rotate it 180 degrees, and connected it up to the hip joint, the ankle will become the new knee joint. It's very difficult to do this procedure. You have to cut, in this picture, it's not performed, but you have to cut the vessels and then re-anastomose them. The nerve is coiled in place, but eventually all of that effort may be worth it because you get a knee that actually works. Definitely not something that we routinely do. This is a case where I've done one of these in fellowship. It was a young patient, I think 19-year-old, with a recurrent distal femur Ewing sarcoma. His hip and lower leg were totally normal. So we did this procedure. You can see the plate that's connecting the femur and his tibia. And that is what it looks like. It's very grotesque looking, but actually patients get used to it. You put the prosthesis on and they have improved function. I'm just going to skip through this. Sorry. Okay. As far as hip dysarticulation, this is a procedure that we try never to do. It's a very morbid procedure. We only do it in emergency situations. Really, if we have no choice, as a life-saving procedure. High risk of complications, as you can see in this study, 26% mortality rate at a month, 60% at 1 year. They have a poor quality of life, high risk of complications. Really, we try to avoid that procedure. This was one that I think this is one of Dr. Goodman's patients that I did when I was a resident. I believe we did together. And you could see how much of a procedure, how much of a grotesque procedure this is, and it's something that we really never want to do. There are many complications that can arise. They're all listed right here. Various complications, including hematomas, infections, wound necrosis, especially if you have a tight closure, phantom limb sensation and phantom pain, neuromas. If you do develop these conditions, there is treatment. This is mirror therapy. You see this gentleman sitting with a mirror, and it kind of trains the mind to understand that the limb is not there anymore. And phantom sensation is the sensation or the presence of the amputated limb. Like you feel your ankle, even though it's not there. It tends to get better with time. Phantom pain is when you have pain in that ankle. You have a Charlie horse in your calf, but you look down and there is no calf. When the mirror therapy doesn't work, there are medications. Gabapentin is routine. We put all of our patients on gabapentin. There are many other options, spinal cord stimulators, if need be. And some cases, this is the first case, 67-year-old. I just did this about 2 weeks ago. He had a myxofibrosarcoma in the lower leg. He did not want multiple surgeries to try to do a limb salvage because this is a very aggressive tumor. He would have to have removed part of the bone, multiple surgeries, and he just wanted to get over with it and save his life. And so this is what we did. This is the amputation. You can see it's a very nice, clean cut. I don't use the sword that many people use. This is a ligashore, and so everything is nice and clean. All that's left in that middle image is the bone, the sciatic nerve, and the vessels to ligate. And that's what the flap looks like. I move the anterior tissue posteriorly, so from the patient's perspective, they don't even see the incision. Another patient, 17-year-old with a recurrent Ewing sarcoma, we had no choice but to perform above knee amputation, similar incision. You see the flap is on the back. And that's what it looks like at 5 months later. This patient had a nasty sarcoma in the lower leg. Again, we had no choice but to perform an amputation. We managed to get away with the below knee amputation while still maintaining negative margins. That's what it looks like early on. You can see the fibula is cut a little bit higher than the tibia. And I don't know if this video is going to work. That's her at 6 months. If it works, it works. But she has very good function. She's very happy. She has no pain. Every time I see her, she just thanks me for saving her life. Next slide, if it works. Okay, so in conclusion, an amputation is really to be considered, like Dr. Goodman said, a reconstructive procedure, not a failure of treatment. And when you consider your options, especially for sarcomas that can kill you, patients need to answer the question, what's more important, your life or your limb? And although it is a last resort, this may be the first step toward a more comfortable and productive life. Thank you.
Thank you, Dr. Khan. We're going to go now to the surgery side on the upper extremity. Dr. Nolan, whenever you're ready. Just unmute, my friend.
That better? Can you hear me now?
Yeah, we can hear you. You're great.
Oh, okay, great. And then let me see how to
Here, I'll put it back up.
Yeah, it wouldn't let me unmute once I had control of the screen. Okay, sorry for that. I'm computer illiterate. So upper extremity amputations, I would probably biasly say that they have a greater impact on function than lower extremity amputations. And so in any setting, I try to avoid them as much as possible. It's why in mangled extremities, we do everything to try and replant or put back on the limb, because the function and dexterity after amputation with the use of a prosthesis conventionally has not been as successful as we have been in the lower extremity. I think with some of our new techniques and the myoelectric prostheses, how they've come along, we may be seeing that change. But an upper extremity amputation has a lot of drawbacks. So 90% of patients who undergo an upper extremity amputation endorse either phantom limb pain or stump pain, and 76% of people endorse having both. The studies used to suggest that pain was not an impacting factor on use of a prosthesis. However, that has also changed over time, with studies showing that about 35% of people actually reject prosthesis use because of phantom limb pain and discomfort. Thanks for advancing. Basically, I'll do anything to avoid it. When I can avoid it, it's when there's a lack of blood flow or we're losing our stability through bony stability or function, or a lot of our nerves. So that you have three basically main nerves to the upper extremity, and as you start losing more of those, you're going to have a dysfunctional limb, and then it's more functional to not have an appendage just hanging from your side. The level of amputation, as we move more proximally, we start needing to rely on a prosthesis for more function. A wrist disarticulation is rarely performed. And I don't talk about transcarpal or finger amputations. I usually think of those more in terms of replant, but those would be the most functional. But wrist disarticulation is rarely performed. Generally, my thought process for when this technique is useful is in a pediatric patient. And the reason being that it preserves the physis, which will prevent bony overgrowth from the stumps. And so it allows you to have a nice long lever arm, but actually our prostheses tend to fit the wrist disarticulations worse than they do a transradial. So in my mind, the reason to really keep the wrist joint is to prevent bony overgrowth in a child. Now, theoretically, it should preserve more pronosupination. So you have generally 180 degrees of this. At a wrist disarticulation, it's thought that you keep about 120 degrees of pronosupination. And as you march proximally in a transradial amputation, you start losing more. And if you get within 5 centimeters of the elbow joint for a transradial, you're losing all pronosupination. And you're lacking prosthesis fit. So this just goes through the wrist disarticulation technique, and you do resect the radial and ulnar styloids for prosthesis fit. For all of my amputation techniques that are available on the slides, I talked about attraction neurolysis, so pulling the nerve, cutting it so it retracts proximally. We have other techniques that I believe Dr. Goodman will be getting into, which I think really advances the idea of upper extremity amputation in general. And so for this, you're dividing the wrist in digit extensors. So what you're going to be preserving is pronosupination, as we talked about, and elbow flexion. You're going to be able to preserve the majority of the sensation. Patients still will experience phantom limb pain or phantom limb sensation, and that tends to be about 12% of people in a wrist disarticulation or a distal transradial. There we go. Okay. So transradial amputation. So now you are trying to be at least 4 to 5 centimeters distal to the elbow joint, and you're going to take it back at least 5 centimeters proximal to the wrist joint. The main drawback here is the distal skin is thinner, more difficult to heal, but having a more distal amputation provides a greater lever arm, which will allow for better function with the use of a prosthesis. Patients are more accepting of prostheses the more distal the amputation is in the upper extremity. And so 70 to 80% of patients will accept a prosthesis for a transradial amputation. And here's the technique. It's very similar. Here now you're going to use a saw to cut the bone edges. There is a modification on a transradial, which I don't discuss necessarily in the slides, but it's called the Krukenberg procedure. It's pretty rare to see over on the state side. But what that allows is you can create a trough between the radius and the ulna, myades, the different muscles, and allow for pincer grasp between the radius and the ulna. With now pronosupination will allow the radius and the ulna to separate and clamp down, and that can be used by a patient to grasp objects. So that's called the Krukenberg, but it's not very commonly performed here in the United States. Here we discussed like myoplastic closure. So a myoplastic closure is when we're taking the muscle and we're closing it to fascia or to its antagonist muscle to just allow for a padded stump. And this prevents skin breakdown and allows for better prosthesis fit. It's different from a myodesis. It's where we attach the muscle to the bone. As we saw with the lower extremity for the adductor myodesis to prevent scissoring out of the extremity. Proximal transradial amputation. So if you have to go within 5 centimeters of the joint, your prosthesis isn't going to fit well, but also you're going to need to either take the biceps tendon off of the radius or take the biceps tendon off of the radius and attach it to the ulna itself. You don't need to necessarily do that because the brachialis will still provide elbow flexion, but the question of how meaningful this will be remains with such a short lever arm. Okay. Elbow disarticulations are probably the least commonly performed of all of the procedures we talked about, and that includes the wrist disarticulation. But the benefit of an elbow disarticulation over a transhumeral amputation is that you preserve the epicondyles and condyles, which allow for a prosthesis to transmit external and internal rotation, which if you cut those off and then you just have the humerus itself, its cylindrical shape does not allow for that without modifications made to the prosthesis. Again, in a pediatric patient, preserving the physis here will prevent bony overgrowth of the stump. Rarely performed, but important to know. A transhumeral amputation needs at least 5 to 7 centimeters of length. Come on, advance.
Click the screen one time and then go forward.
Okay, there we go. Thanks. Here you need what we talked about, like the modification to the prosthesis to allow for rotation. You can do an osteotomy to the humerus to provide a flexion moment to make the prosthesis positioned in a better spot. About 50% of patients with a transhumeral amputation generally have not used their prosthesis previously, and most require some sort of strap on the shoulder to maintain the prosthesis position. And it's because as we move up, it becomes less and less functional, and with higher rates of phantom limb pain. Supracondylar transfemoral amputation is just you try and distalize it as much as possible, whereas as you move more proximal, you again lose that lever arm and start losing function. A shoulder disarticulation is when you really don't have any limb salvage option for the amputation itself. You do maintain the glenoid and the scapula. And that's what differentiates this primarily from a 4/4 amputation, where you're actually removing the entire limb from the trunk. And that has to do with the location of the tumor, if you can preserve that. I prefer a shoulder disarticulation over a 4/4. I think it allows a strap to be placed over the shoulder still. Women can still use purses as opposed to when you lose the contour of the shoulder with a 4/4 amputation. And I think that's really about it to discuss for this. I mean, you have the different surgical techniques, but really the take-home points I would say is if you can save the limb in an upper extremity, that's always preferred for lower extremity as well. Phantom limb pain is very common, as is stump pain in the upper extremity. These do preclude or cause patients to be less likely to use different prostheses. The more distal the amputation, the more native function that's preserved, and the more likely the patient is to use a prosthesis to try and get gross and fine motor. Outcomes for gross motor are best with a transradial over a wrist disarticulation, but transcarpal are still the best in terms of those, and the updates that Dr. Goodman will talk about in terms of targeted muscle reinnervation have really changed the landscape of upper extremity prosthesis use, as well as the treatment of phantom limb pain, which has been a bane for surgeons in terms of upper extremity amputations thus far. All right. Thank you.
Thank you, John. Thank you, Dr. Nolan. So now we're going to take a couple minutes before we move on to Dr. Aresti and Bill Keltz and see if there are any questions for the surgeons. Some of this was very surgically detail-oriented, which was a little bit of the point to give everyone a view into how we are viewing these on a day of surgery basis. So it's somewhat of our philosophy going into the surgery with a plan for afterwards, as well as what we actually do during surgery. Some pictures and some just deep thought processes. Anyone have any questions? Please feel free to put them into the chat right now for the surgeons. So while we're waiting to see if anyone has any questions, I think it was great to see Dr. Kanan's slides, especially some of the cases that you did. Can you tell me a little bit about how you talk to patients before the surgery, or what your approach is as a surgeon beforehand?
Yeah, thanks. Basically, as you're also familiar with, we have the luxury of time for these patients. It's not always an emergency amputation that needs to be done. Yeah, in the setting of trauma, infection, those are emergencies. But we generally do these as life-saving curative procedures for sarcomas as a last resort. We prepare the patient. This is not something that we're doing tomorrow. It may be done in the next few weeks, maybe a month later even. And that gives us some time to mentally prepare those patients. Like the patient I just did an above knee amputation on 2 weeks ago, I must have spent, I don't know, maybe at least 10 phone calls for the past month in preparing him and guiding him through. And so he was very mentally prepared, ready for the surgery. Some patients can be started on gabapentin even early on at a low dose to get them started. There are many associations out there that you can connect them with. There's the amputee, I forgot the name of it. There's an amputee coalition that they can reach out to and actually talk to other amputees to hear their experiences. And having a good preparation like that really helps them get through the procedure.
Thank you. There's also a question, I think, because of one of the pictures in your talk. Marshall, one of the orthotists, was asking plaster IPOP or immediate postoperative prosthesis. You had one of your patients in a plaster immobilization. Can you mind commenting on that?
Yeah, so that one was a baloney amputation. The problem with these amputations, as you know, is that the dressing that you put on, you could put whatever fancy ACE wrap, Coban you want to put on, it will fall off. So if you want it to stay on and not to fall off, some will put a plaster splint cast around it just to protect the incision, to prevent people from looking at the incision. You want that to heal. That's the way that my father, Samuel Cannon, he's now retired. That was his technique. He would put a cast on, but it's bulky, it's heavy. I think now I probably wouldn't put a cast personally, but many people do that. I would just keep a close eye on it, and if the dressing falls off, I would just redress it personally. Dr. Goodman, do you cast your amputations?
I don't cast patients unless I'm very worried that they're gonna have that they're gonna have some sort of contracture. For example, Marshall just wrote, extend past the knee, prefab IPOPs are available, and which is great for us to know. Often with ours, we're worried about the skin, so we want to see the skin in particular. So if I'm going to cast someone, it's because I'm going to cast them to avoid a contracture. Usually that's going to be right below knee and keep them in extension. So that's one of the points of this, Marshall. Thank you for bringing up so the subject. We have our own little world also that we don't get to see as much of the orthotist prosthetist world, and we always need to learn more. So using the immediate post-op prostheses or immobilization is a great thing that we should all be involved with. Very often, at least for mine, I need to see these very quickly, and I need to see the skin very often. You mentioned we don't do these emergently. I actually was just called in to another hospital last week to do an emergent transhumeral amputation. So that's a patient that I'm going to want to see their skin often. So I'm not going to necessarily put something on that I can't, like a cast, but I think a lot of the prefab IPOPs are able to be taken on and off. There you go, held on by Velcro. So that, as I said, they're easy to come on and off. So this is something where, as we move forward, and I'll discuss this later, instead of having everyone in their own worlds, and if a patient with an amputation gets there, great. I'd rather have us all together as a group, and so that we can work together, especially for the patients who we have a week or 2 weeks before we need to do their surgery, and it's not the next day. Have everyone involved. And I'll discuss later who we think should be involved. But Marshall, you bring up excellent points, and again, why we're doing this all together. Dr. Nolan, question for you. You mentioned that a lot of patients just don't end up not wearing prostheses for upper extremities. Do you think there's anything you can do either preoperatively, postoperatively, or in counseling that can help them be more functional?
So, well, operatively, you're going to touch on it, but the targeted muscle reinnervation, which you'll introduce to the group, I think is really what allows us to utilize a prosthesis more functionally. the myoelectrics now and have better signaling for non-myoelectric prostheses, because a lot of patients can't get approved from that. Getting patients in an early or an intermediate time frame to start working on fit of the prosthesis has been shown to have better compliance and use post-operatively. Intermediate time frame was actually noted to be within 2 weeks, and this is in an injury amputation, but it could apply to tumor because you have time to plan this out. And early was within 1 week, and late was, I believe, up to a year afterwards. So anywhere from 2 weeks to a year was thought of as late to start prosthesis fitting. Now, I generally don't start that early, to be honest. So it was interesting to review the literature myself because I usually try and get us to use like shrinker socks or something to shrink everything down before you can get actually the final prosthesis fit. But for patients who were fit for a prosthesis, and then for patients who began rehab with the prosthesis within the first 2 to 3 months, there's a higher compliance rate with using the prosthesis overall. I think also if you're beginning rehab sooner, you can address some of these phantom limb sensations and phantom limb pain, which are related to prosthesis use.
Thank you. So again, the collaborative effort of having patients meet with a prosthetist beforehand and be able to know about all these different options, in addition to us, is going to work. If no one knows, it's going to be impossible for us to get one of the prefab immediate post-op dressings for our patients and put them on in the OR or in the recovery room. So having a little bit of time and having a thought-out process and a pathway for these patients I think it's gonna be great for everyone all around. Most importantly, the patient. So along those lines, I think it's time to move over to Dr. Aresti and to have the beginning of his talk now. Dr. Aresti is a physiatrist, physical medicine and rehabilitation, and in the Northwell system, which has I think 48 or 100 or something employed physician, he is by far going to be the expert on patients with amputations. So I'm excited to hear what he has to say. And Tony, please.
Good evening, everyone. Thanks for the introduction. You can hear me? Sorry, I can see if my audio is on or not. Are you able? Yeah? Okay.
Yes, we can hear you. Thank you.
All right. So I've been charged with discussing preoperative preparation and postoperative management in amputation. So I'm just going to jump right into it. So for preoperative preparation, early assessment, and rehab planning prior to surgery is a great way to help prepare patients for their upcoming rehab program. And hopefully providing education and exercise prior to surgery will shorten the time to prosthetic fitting, prevent secondary complications such as contractures, and ultimately achieve a maximal functional outcome for the patient. This opportunity typically is not available for vascular and diabetic patients, but can make a significant impact on patients in an oncology program who are awaiting elective procedures. So firstly, it gives an opportunity to introduce the patient to the rehab team, which includes the physical therapist, occupational therapist, the certified prosthetist and orthotist, and the physiatrist. And this will not only allow the patient to feel comfortable with the people who will be providing the rehabilitation, the people who will be fabricating their prosthesis and providing continued outpatient prosthetic care, but can also instill some confidence in the patient and help develop a relationship that will improve patient compliance with the care provided down the road and postoperatively. Excuse me. Reviewing the anticipated upcoming rehab program that will occur in the acute hospital stay, inpatient and outpatient rehab settings, and home services can help alleviate anxiety and hopefully motivate the patient to achieve their expected goals. It's also an opportunity to assess socioeconomic issues, insurance issues, and the patient's home environment to preemptively address any challenges awaiting and avoiding delays in treatment and equipment postoperatively. And education for the patient is key preoperatively. It can give the patient an understanding of postoperative wound care, but also stress the importance of edema mobilization to enhance wound healing and stump shaping prior to prosthetic fitting, and hopefully motivate the patient to comply with the postoperative care. Patients should understand what a joint contracture is, which ones they're at risk for, and how they can have a negative impact on prosthetic fitting and ultimate function with the prosthesis. Hopefully, this will motivate the patient in their preoperative training program and compliance with proper limb positioning down the road. They should be aware of the benefits of prone positioning for the above knee amputee and for the discouraging the use of a pillow behind the knee and the below knee amputee to help prevent hip flexion and knee flexion contractures. And other areas of education include phantom limb sensation. And particularly, this could be an issue because when the patient still has an awareness that the leg is there, it can definitely lead to falls in the postoperative care. Patients can get up at night, not recall that they had an amputation, and typically they'll end up falling on their residual limb. So getting some good education may hopefully prevent a fall in the postoperative care. And of course, also addressing issues with the patient in terms of potential for phantom pain and treatment options that will be available if this becomes an issue postoperatively. I'm going to leave the rehabilitation to the next speaker, but I'll just say that starting a structured exercise program as soon as possible should occur and can include transfer training techniques and the early use of walking aids in the preoperative phase, and that could help shorten the time to independent care for the patient postoperatively. Let's take a look here. Oh, I hit it twice. I'm sorry. Could we go back one slide? Thank you. So for early postoperative management, we've been speaking about soft and rigid dressings for the patient. As I said before, edema mobilization really is a key aspect of postoperative care. Limiting edema facilitates wound healing and will result in earlier application of the prosthesis. It helps prevent hematoma and seroma formation in residual limb, which can delay healing and can also risk wound dehiscence postoperatively. So, it also facilitates conical shaping of the residual limb for better prosthetic fitting and hopefully reduce the need for frequent prosthetic socket replacements. And this typically starts with the soft dressing options such as figure 8 ace wrapping over the patient's wound dressing. Once the staples or sutures are DC'd and there's limited eschar or scabbing over the wound, a stump shrinker can be applied, which is basically a sock that goes over the residual limb that provides distal pressure to help mobilize the edema. You can also apply the figure 8 ace wrapping over the stump shrinker to enhance this distal compression and aid in mobilizing the edema. We spoke about rigid dressings and removable rigid dressings, and they include plaster molded dressings as you saw before, but it can also involve plastic dressings as well that can be removable. When these devices are applied immediately post-op, they have been shown to decrease formation of edema, decrease healing time, and also decrease the time to prosthetic fitting. And they can also enhance the conical shaping of the residual limb. The problem with these devices, which has been touched on, is they are heavy, they can cause abrasions to the residual limb due to friction, and they also decrease visualization of the wound. And for these reasons, you generally don't see them in use in our vascular and diabetic patients. However, for an oncology program of elective non-ischemic amputations, a removable rigid dressing can be incorporated into the program for the reasons I mentioned above. Another key aspect of postoperative care is positioning and range of motion exercises to prevent joint contractures. Hip and knee flexion contractures can result in the need to provide flexion to the prosthetic socket, and the use of what's also what are called offset adapters which have negative effects on patients' ultimate gait mechanics and functional ambulation. So obviously, a key thing is to try to prevent these type of contractures. So proper positioning is very important. It's important to have the above knee amputee patient spending some time in the prone position and potentially even putting a pillow under the patella to help enhance stretching of the hip flexors. In the BK, and obviously you shouldn't use a pillow behind the knee in the below knee amputee because it can enhance positioning into hip flexion and knee flexion. And the early introduction of dynamic stump exercises and range of motion exercises a necessity to prevent contractures. Isometric strengthening exercises can be added 1 to 3 weeks after surgery. Isotonic strengthening exercises are typically added after 3 weeks postoperatively. Next up, we have optimizing functional abilities with early transfer training and the addition of walking aids such as a rolling walker or the iWalk device. I'm sorry, I should have got a picture of the iWalk device. It's basically a device where the patient with a below knee flexes the knee and it's basically strapping on to a crutch onto the lower extremity. I just had a patient last week who was in the mid-40s, diabetic patient, diabetic infection. And I was seeing him for the first time to give him his to prescribe him his first prosthesis, but he literally walked into my office. He did an internet search, found the iWalk, went on Amazon, purchased it, applied it to himself, and started using it. And he was walking in my office independently without any assisted device using the iWalk device. So this is something that really can be incorporated into an outpatient rehab program in terms of training, especially for the BK, for the below knee amputees. And getting a patient ambulating that early and that effectively can also help justify the K level for the patient. So what a K level is how ambulatory is this patient? So let's say a K4 would be an athlete level patient. K3 is someone who ambulates in the community and can adjust their walking speed. So if you can get a higher K level justified for the patient, that helps with insurance authorization to get the patient higher end equipment for their prosthesis. Next up, we have desensitization techniques. Obviously, after surgery, the residual limb can be very sensitive, and desensitization techniques can be used by therapy to help control pain. There are therapeutic treatments such as gently massaging the residual limb, vibration techniques, light tapping of the residual limb can all help manage and desensitize the limb, and also can help prevent skin adhesions. So from a prosthetic standpoint, if the wound heals and the skin gets adheres down to the bone, this is a prosthetic challenge because that skin is susceptible to shear forces and can easily break down and becomes friable skin. So if we could prevent skin adhesions from forming postoperatively, that certainly helps the prosthetic fitting of the patient. Applying constant pressure, either manually or via a stump shrink, it can also help in terms of the sensitivity of the residual limb. Getting into addressing phantom limb pain is important postoperatively. 75 to 80% of patients can report symptoms of phantom pain. Treatments include analgesics. I like the aggressive use of gabapentin and Lyrica. We saw I saw a slide of mirror therapy as a way to help manage it. However, you should keep in mind that just the application of the silicone liner and wearing the prosthesis can help with these symptoms as well. So we can also encourage the patient that once we get them fitted with their prosthesis, it actually can help with their phantom pain, especially in the lower extremity amputee. And for the more refractory cases, obviously outpatient pain management service, acupuncture also has been a modality that's been helpful in managing phantom pain. And then finally, we have the actual application of the prosthesis itself. I mean, obviously, the residual limb should be well healed and ideally for the prosthesis, but that's sometimes not the case in the real world situation. sometimes these residual limbs have eschars or scabs that are there that could really delay the prosthetic fitting. In the old days, we used to use whirlpool treatment to help sort of debride off this eschar. It was very effective. However, whirlpool treatments are, require more intensive manpower. There's sanitary issues, and they're generally not used anymore. But they were very effective. I have found with the below knee amputee that if a patient develops a large eschar that's sort of delaying prosthetic fitting, we could actually go with the elevated vacuum suspension with the below knee amputee and apply it. And it actually helps very nicely to debride off that eschar and encourage wound healing. And it gives the advantage of getting the patient mobilized and fitted with their prosthesis sooner. Lastly, there are multiple factors that come into this in terms of their premorbid condition. Psychological factors will ultimately impact how soon and how successful the prosthetic fitting and use of the prosthesis will be. So addressing some of these psychological issues in the postoperative phase especially can also help get patients further along in their prosthetic journey. So that's basically what I have.
Amazing. Thank you, Dr. Oresti. Really stuff that we all need to hear on a regular basis. So thank you very much. There are a couple questions which we're going to take after Mr. Kelce's talk. So I do see the questions. I appreciate them. Please put them in as they come up, and we'll address them. But now we're going to move on to Bill Kelce's talk. Bill is a physical therapist with STARS, the Northwell Rehab Network, and also excited to hear what you have to say. Thank you very much for being here.
Thank you, Dr. Goodman. Yes, my name is Bill Keltz. I'm a physical therapist with STARS in Bayshore, South Shore Hospital, and I'm a member of our oncology rehab team. Our learning objectives are going to be a brief overview of prehabilitation, PT evaluation, PT intervention, patient education prior to amputation, and a brief overview of prosthetics. So a rising body of evidence shows that optimization of patients' physiological, physical, nutritional, and mental status in the preoperative setting may improve the overall surgical outcome. Prehabilitation allows the opportunity to improve functional tolerance for any upcoming treatment, such as amputation, even chemo, radiation. It reduces post-treatment symptom impact, facilitates and helps prepare for functional recovery, possibly reduces hospital length of stay and emergency room returns, and promotes physical activity, which is effective for reducing mild to moderate symptoms of depression, anxiety, and psychological distress. In a 2022 study, patients undergoing major lower limb amputation who received multidisciplinary prehab had reduced hospital length of stay compared to matched control patients. In another study in 2021, a meta-analysis, it was indicated that prehab for cancer patients can improve postoperative functional capacity and patient survival. The results support the incorporation for prehab for cancer patients in the NCCN guidelines. Okay, this graphic shows the timing of prehab in the cancer care continuum. So first you would get the cancer diagnosis, and then prehab, there might be an opportunity for prehabilitation in terms of sarcoma or other oncology reasons. And so we'll hopefully do some prehabilitation, and then the cancer treatment, such as the surgery itself and any other treatments, and then rehabilitation afterwards. This graphic shows the pillars of support for prehabilitation. So the three pillars of support being nutrition for the patient, psychologic support, and physical therapy, OT, and rehabilitation. And the basis of support for all this is the medical optimization of the patient. So this graph shows that both the quality of cancer care and the ability to assess and potentially improve physical and physiological outcomes are best, as you can see to the right, when prehabilitation is in the picture. So I'll go into what we'll do when we get a patient to our office prior to an amputation. But first, we'll want to take a subjective, gather the patient's main complaints, present and prior functional ability, and their goals. Get a good past medical history, cancer history, treatment history, medications, precautions, and social history. So then we'll go into our objective. We'll do an observation. We'll look to see if there's edema, skin integrity issues, any scar tissue issues. We'll look at their functional mobility, their transfers, gait, stairs, look at their balance, range of motion, strength. We'll do a neuro screen and look at their endurance. Some examples of outcome measures that we may use for the patients are listed here. There's the dynamic gait index, functional gait assessment, Berg balance test, 6-minute walk test, timed up and go, 5-time sit to stand test, lower extremity functional scale, and also take note of the revised musculoskeletal tumor society rating scale, or the MSTS. So the MSTS is a questionnaire for the lower extremity, and it's composed of 6 items, including pain, function, emotional acceptance, use of any external support, walking ability, and gait alteration. So each item is rated on a scale from 0 to 5, and the total score ranges from 0 to 30, with higher scores indicating better function. Here's a chart of the MSTS, so you can see all the items and the scoring here. Okay, so moving on in our evaluation, as far as assessment, we'll want to just make a note of our summary of deficits and the overall functional impact of these deficits on the individual patient. We'll want to take a look at any barriers and facilitators to the rehabilitation and make a statement indicating the need for skilled intervention preoperatively, and also we'll want to do that postoperatively. Then we'll go into our plan and goal setting. So our goals for these patients should be related to function, and they may include mobility, outcome measures, strength, balance, range of motion, any concerns preoperatively that they may have for contractures or what to expect, endurance, patient education, and any pain goals. Examples of a functional goal, short and long term, are listed here. And moving on to intervention. So our treatment for these patients, we'll always want to be to monitor for and be mindful of any edema or lymphedema, pain, fracture risk, neurologic involvement, side effects of chemo and or radiation that they may be receiving. Example, low blood counts, fatigue, etc. Psychological factors associated with both the cancer diagnosis and facing the upcoming amputation. When in doubt about any precautions or restrictions, communicate with the physician. So in an intervention specific to the non-amputation extremities in the trunk, we'll want to just progress them gently, depending on the patient and on their tolerance. Here's some examples of strengthening exercises that we may want to do in terms of the other extremities. Moving on to the pre-amputation limb itself, we're going to focus on optimization for post-amputation prosthetic use and for functional recovery. So we may include focus strengthening, Stretching, range of motion. Here's some examples of some stretching exercises. And always, like I said before, take note of any precautions. And an example of a precaution that we may receive from the physician may be avoiding extremes of range of motion or low or no resistance, any weight-bearing restrictions. So our functional training for these patients, we want to consider the changes that the patient will face after amputation so that the patient can be prepared in advance. We want to consider future biomechanics changes. We'll want to do gait training, stair training, assistive device training, transfer and bed mobility training, balance training. And we'll also want to look at their endurance and cardiovascular activity and exercise is usually important here. And we want to promote improved functional endurance and activity because the demands are going to be higher after surgery for the prosthetic use and even before prosthetic use. So if we can get them on a program, for instance, like an upper body exercise routine or any of these other examples here for increasing the cardiovascular activity. And a home exercise program preoperatively should be safe and functional. It should address their deficits and maintain or optimize function and overall fitness. We want to optimize strength, range of motion, endurance, balance, posture. And patient education. People who understand the process have realistic expectations of the difficulties that they may face and the most probable outcomes are the ones who are most likely to persevere and have a better result. We'll want to provide resources. So examples of resources would be amputee support groups, organizations, even information about adaptive sports that they might be interested in, prosthetists, and home or automobile modifications. So some ideas for later on that they may need to modify their vehicle. In terms of prosthetics fitting, it could vary, but usually around 7 to 10 weeks post-operatively, we might start thinking about this. And after sufficient surgical incision healing, edema reduction, range of motion, and strength has occurred, temporary socket or prosthesis may be used, and socket adjustments will expect to continue for 6 to 18 months until the residual limb shape stabilizes. There are many different options for prostheses, but all aim to achieve a stable, comfortable fit for maximum function. They can be designed for general daily mobility, for specific activities such as swimming, for high impact and competitive sports. There's around 350 types of ankle and foot systems and around 200 different types of knees, maybe more, probably more. And here's just an example on the left of a below the knee prosthesis and on the right and above the knee. There's many different types of suspension systems. Here are some examples. We got the vacuum system, passive suction, interface with locking pin, the anatomic suspension system, belts and straps may be used, and the newest one would be the osseointegration prosthesis. So that's a surgical implant into the bone. In December 2020, the FDA approved this procedure for amputations who have or anticipated to have rehab problems or cannot use a traditional socket. And finally, I just wanted to talk about K levels. Dr. Aresti mentioned. So they're used by CMS to ensure uniformity in determining which prosthetic options are medically necessary for each patient. So the higher K level, the higher level prosthesis the patient may be eligible to receive. So a hypothesis could be made that prehabilitation for amputation due to sarcoma may help to improve overall outcomes and may improve their K level. So specific research is underway and more research is certainly needed on this topic. Here's my references, and I think that's all I have. Thank you.
Amazing. Thank you so much. It's really, I think, great to see all the different points of view when we're taking care of these patients. We kind of all go to our own offices and our own worlds, but we're all taking care of the same one patient. So seeing how everyone does it, how we think about it, and how we come together is great. I'm going to talk a little bit more about Oprah shortly, so that we're all a little bit more familiar with it. But there are some questions for the second group. One of the questions: can you advise about MRI compatibility of prostheses? I'm not sure that this group is the right group to do it. Most of the time, I would say that the prostheses that are able to be removed, which is the vast majority of them, should be removed before an MRI scan. And then in terms of a prosthesis like the Oprah, which has osseointegration and stays inside the patient, they're made of titanium. They are MRI compatible. They can heat up because they're a big piece of metal. So the recommendation is that you move them out of the central area of the MRI scan for about 20 centimeters. But that's that. Hopefully that answered your question. And someone else asked, and I'm going to say this is for both Dr. Rusty and Mr. Kell. Sorry if I missed it, but when does the pre-op training education occur?
It can occur, as soon as possible. So you'll have the cancer diagnosis, and if it seems to be going down the road of probable amputation, it can begin as soon as possible up until the time of surgery itself.
Dr. Rusty, I think you're muted. I think you had an answer for that also.
Oh, sorry about that. I muted myself. Yeah, no, early, when a patient gets a diagnosis, and again, there's a sense that this is coming down the road, the earlier you get the patient into the program, the better. They get more conditioning, more education, and hopefully you'll get a more motivated and compliant patient post-operatively.
And that's why we try and get these done as soon as possible. As soon as we're making the diagnosis or we're indicating them for an amputation, we try and get them over as soon as possible. Another question from Dr. Adi in the UK. When do we use baclofen in patients with joint contractures and muscle spasm? And is this NSAID safe with PPI cover of past history of peptic ulcer and heart failure and nephropathy? I'm not sure that this is the right place, but if anyone's going to answer that, I think Dr. Rusty, that's you.
Well, I mean, baclofen is more for addressing spasticity, so I probably would not use that as this is sort of a spasm treatment overall for the patient. I generally use it just for patients who have stroke, upper motor neuron syndrome, and spasticity management.
Thank you. I agree with that. I think baclofen has use. I think for real contractures, surgical attempts at something as well as using Botox can be helpful.
Yeah, again, if patients have upper motor neuron syndrome with that's causing their contracture, right? There's phenol nerve blocks, botulinum toxin injections. If the residual limb has enough size to it, you could even do custom bracing, static progressive stretching to apply static progressive stretching to the limb. Otherwise, if that fails, then you're looking at a surgical option.
So, trying to work ahead of time, I think, is really important to educate the patient and like you're saying, tummy time for a transfemoral, that kind of thing.
Yeah, the best way is to prevent it from happening. So, making sure the patient is aware of what type of contractions they're susceptible to and what are the exercises to prevent it, and having them aware of what the complication of that would be in terms of prosthetic fitting, impairing their gait. It'll help get that patient on board and compliant with their program.
We had a question from Dave Marcello. What is the average length of stay? I'm going to assume you mean in the acute rehab. Whoever's controlling, can we try and go back on the slides to the question and answer? And we'll get to the rest of the stuff. So, what is the average length of stay? And I assume it's going to be for acute rehab for right after an amputation.
For acute rehab or length of stay in the acute hospitalization?
For us, for the acute hospitalization, it depends where it is and what else is going on with the patient. Usually for us, it's anywhere between 2 to 5 days, assuming that the reason they're in the hospital is the amputation.
Yeah, from the acute inpatient side, again, it also comes in what are the comorbidities of the patient, complications, but average length of stay is probably in the 7 to 10 day range for acute rehab. In the subacute world, it's a longer length of stay.
Thank you. Another question I see, question for the physicians. What is the general prognosis for the post-op below knee cancer group, aged 4 to 60 years old with no other conditions? I mean, I can give my thoughts, but Shachar, you want to take this? General prognosis for post-op below knee cancer group, age 40, 60 years old with no other conditions.
Wait, where do you see the question? I'm sorry.
This is in the chat.
I don't. Oh, yeah. Okay, between 40 and 60. The prognosis in terms of survival is entirely dependent on the oncologic margin and whether or not the tumor has spread elsewhere. But if the tumor has not spread elsewhere and you're able to get clean margins, the prognosis is for survival is excellent. As far as the prognosis, as far as the function and the limb itself and soft tissue, wound healing issues, that all depends on comorbidities. But in a young, healthy patient with a good surgery, it's very good.
I agree with that. I think the answer is really going to be very much dependent on what exactly the disease is. For when you're talking about prosthesis, you're talking about prognosis for in terms of survival. So I think that's the answer to that. I have another question. What intervention is appropriate to arrest contractures due to RA, to rheumatoid arthritis? I think that may be outside of the field of our talk, but Dr. Nolan, do you want to? You probably see a lot of rheumatoid arthritis as a hand surgeon more so than we do. Contractures due to RA. Anything you want to add to that?
Can you repeat the exact question? Because I just don't see it.
It says what intervention is appropriate to address contractures due to RA. So I'm going to assume that means rheumatoid arthritis. Again, a little bit outside of this talk, but
Yeah, because I generally don't think of RA as a disease with contracture. So because it's more like inflammatory arthritis causes more soft tissue laxity. Generally, when I think of something being immobile from RA, I think of it in terms of either tendon ruptures or joint dislocations, and predominantly. And so I address getting kind of stability of the joint, and then repair of the soft tissue structures, and then I tend to immobilize that for 2 to 3 weeks afterward, just because I think of it as something that wants to stretch out, and then I start to mobilize. But generally, when someone comes to me with RA, I'm not seeing them contracted in the office in the absence of having some kind of a soft tissue rupture or joint dislocation.
yeah, I similarly will add in that the ones that I'm thinking of are on the arthroplasty or joint replacement side of my practice. It's the patients who have significant soft tissue laxity, and for example, a RA knee is going to more likely to go into valgus and maybe have a flexion contracture because of their severe valgus, rather than because of the rheumatoid. Certainly, you can have the large masses from rheumatoid that can cause contractures, and from our point of view, those are going to be mostly handled by the rheumatologist and by the biologic medications. We don't see as bad, or certainly in the more proximal joints, we don't see as bad RA destruction as we used to. I think hand is still active, but again, the numbers are significantly down. Dr. Rest, do you have anything to add to this? Even though again,
not really. This good management of the underlying rheumatoid arthritis. If a joint is contracted, especially in the hand, once these joints show contraction, it's very hard to get that range back. So there's not a lot of great bracing options to try and reduce these contractures.
Okay, so I think we're going to move on. There's one more question, is, will the advancement of Neuralink and future bioengineering make recovering easier, and how so? It looks like Elon Musk asked this question. But Neuralink, future bioengineering, I'm going to kind of move into the last part of the talk here, which is a little bit more of the state of the art, what we're up to right now, as opposed to what the future will bring, but it may give you a little bit of a window into the future. So again, going onto horizons, thank you for mentioning Oprah before. This is one of more than one type of implant, but this is the only one that's FDA approved in the US. So OPRA stands for Osseo-Anchored Prosthesis for the Rehabilitation of Amputees. It's a titanium and titanium alloy system that is dealt with usually with two surgeries, and sometimes can be one surgery. The people who are doing it are pushing it, but it's indicated for two surgeries. This can be done, the first surgery can be done concurrently with the amputation, or it can be done later for a patient who's had an amputation for many, many years and wants to try and undergo this. This is also an option for them. So, so what you can see here on the left is an X-ray of the first stage, which is after the amputation. The first part, the fixture, is put into the bone. You're waiting, and you can see that it's really screwed in, and there is like a lever that you have to hold like this and turn like this. With it's not just like a little screwdriver. You're really putting a lot of force in on this in order to be able to put this fixture into the bone. And then you are waiting the time in between the first and second stage for osseointegration, which is where the implant has the bone grow onto it, both because of the material as well as the way it's made, so that the bone can continue to grow into the threads and secure this very tightly. Come in later, they say 6 months. Most people are doing 3 months, where after you've set up the appropriate soft tissue support, and it's not just the bone and then the skin, there's a significant amount of soft tissue you want to put at the end. Then you can see that there is an abutment that goes through the skin. It's transdermal, comes out through the skin. There's an abutment screw that then attaches to the prosthesis. So that's usually the second stage to create the stoma. And then once you create the stoma and put this through, it needs some time to mature. But this is a way of connecting a prosthesis directly to a bone, and there's lots of good reasons for this that we'll talk about. You can see there's the OPRA for transfemoral was the one that was approved in December 2020. However, they have transtibial. They have pretty much everywhere where you might want. They have transhumeral implants. They have thumb implants for a thumb amputation to get an osseo-integrated thumb. I don't have a picture of that, but again, it's a nice thought, and Dr. Nolan just got a big smile and lit up for that. So having this as something else to do, both in an acute amputation and selling the patient on that now, as opposed to someone who's been living with their amputation for however long, if their bone is good enough, this is something to possibly offer, especially our very functional patients. So you can see the data on the follow-up of 51 patients. This is a Swedish implant. There's a gentleman in the last 40, 50 years who came up with this idea. Now his son is also a surgeon who runs the company, but is also a surgeon who kind of brought it into today's age. They're, as I said, a Swedish company. Superficial skin infections, 55%. My colleagues who I talk to about this, they say that about every other year, a patient is going to have some sort of superficial infection, inflammation, something where they give them antibiotics. The patient already kind of just has antibiotics in their house ready to go if they see a problem, and then they can see their doctor. But once every 2 years, they get something that's handled with oral antibiotics, and it gets better. Loosening, 6% is quite low for the amount of force, as you can imagine, that's going on with a prosthesis going into somewhat of a short lever arm. Loosening of 6% is really not bad. Pain, 12%, is multifactorial, could be from the implant, specifically in the bone. Periprosthetic fracture is obviously a worry, and then the skin necrosis needs to be done the right way. Often this can be done in conjunction with plastic surgeons, or once you get enough experience or you feel good enough, you kind of do it yourself. So again, this is one of the new things we do. This is a short transfemoral amputation. The picture's here. You can see the amount of work that is going to be used in order to get a socket onto this patient, and you see these clamps that might even involve a hip girdle to keep it on them for such a short stem. But at the same time, we want to get them as appropriate as possible. And you can see that there's a lot of muscles pulling on this. As we would know for something short like this, they're going to be pulled into abduction, and that's going to make a difference in where they're bearing weight and things like that. The picture on the right with the osseointegration, obviously this patient has had OPRA, and even with the same length, their bone is in better alignment. So the forces are going through their ankle, through their knee, through their hip to their spine, as if they had their limb still. And again, you can just see the alignment, and the fact that they don't have a socket or anything like that, it just is going to be easier. So between the socket fitting issues, which our orthotists, prosthetists are very used to dealing with and can minimize as best as possible, with osseointegration, once you get the bone to ingrow into the implant, you have this direct connection between not just the prosthesis and the bone, but the bone and the ground, or the bone and whatever object we may be working with an upper extremity. So you can see this osteoproprioception or osteoperception, whatever you want to call it, is how the external stimuli can go through the implant going to the bone. And there's actually electronics you could put in to give even more of that. So more natural greater control and the risks we spoke about before. So this is on the horizon, and it's not even on the horizon. It's happening. It's here. It's in New York. We're bringing it to Northwell in the near future. But this is something to think about for patients who not only are going to need amputations, but who have had amputations, who have been working very well with a prosthesis, want to continue working with a prosthesis, because obviously one of the problems, as you can imagine, is for someone who's already had an amputation, that their bone is just not strong enough because they haven't been bearing weight. So if they're very osteopenic, you are going to increase the chances of fracture, and it's just more worrisome. Something else we mentioned in a few of our talks is phantom limb pain and what to do about it. So this can be done. Some of these things are different techniques to do during surgery, the initial surgery, and some of them are if patients are coming back with neuromas, if they're coming back later and you want to do something to make them more functional, these are ways to do it. So kind of the from simplest, the ABC is simplest to most complex. A is where you just take a nerve, you cut off the neuroma if it's a problem, or to prevent neuroma, you get a limited amount of nerve. You try and limit the amount of length, and you just bury it into muscle. So it's kind of literally an ostrich, so it doesn't know what to look for, and it just kind of is to prevent a problem. The next more invasive is the regenerative peripheral nerve interface. Again, used for if you need to deal with a neuroma for postoperative pain, and this is taking another piece of muscle, an allograft muscle, and wrapping it around the end. Sometimes that muscle can be used, but it's more to stop the nerve interface, which is the cut nerve after you do the amputation, trying to stop the appropriate regeneration to something inappropriate, and a nerve that's just looking around for something to do and not finding it. It's going to go onto a muscle and say, oh, I'm supposed to do something with muscle. I know something to do, and kind of give it a little bit more order when it's trying to regenerate, because as things do in our body, they try and regenerate. More involved is targeted muscle reinnervation. If you don't know about this, it's really important for amputation care. Targeted muscle reinnervation is when you take a nerve that you're going to be cutting and you reattach it to a muscle, to a nerve going to a muscle. So instead of just attaching it to the muscle, there's a nerve muscle interface or a little paddle where the motor nerve comes into the muscle. You take this big nerve and you kind of attach it to this really, really small nerve going to the muscle. Two reasons for that. One is it's kind of like RPNI, and that you're giving a function to this muscle, to this nerve, that otherwise wouldn't have been done. But at the same time, you're also able to give this muscle more support and possibly use it for something else like function. And then relocation nerve grafting is if you have a neuroma, you want to bury it into something, you can take an allograft nerve to just get more length and bring that nerve to be buried into muscle completely far away from the zone of injury. So it is another way of handling this, preventing phantom limb pain. Phantom limb sensation, as we always talk about, is normal, takes time. Phantom limb pain is pathologic, and we want to try and avoid it. So we doing all these things is something that we actively do in our amputations, upper and lower extremity. I'm gonna do TMR on my amputations to prevent problems and possibly restore function. Targeted muscle reinnervation. The point of it, it gives a pointless nerve something better to do. It helps prevent neuromas and prevent phantom limb pain. As I say here, this is something you can do at the time of amputation. Depends on what you're doing the amputation for. If this is trauma and get them off the table, you're not going to do it now. You're going to get rid of the diseased tissue and get out of it. If this is something where you have a little bit of time and you're working reconstruction and you really want to think about the future, taking the extra time to do it, once you learn how to do it, it can take 15 to 20 minutes per nerve or more, and you have to find the appropriate place, and you're using a microscope or loops and very, very small sutures to reconstruct nerves. But it is certainly something to do if you can. Later on, you have to start hunting for nerves. You have to start hunting through, through a previously surgerized field. But it certainly is done, and it's kind of described as being done later after the original injury. So this is just a picture of how we can take nerves that otherwise wouldn't be used and what we can use them for. So you can see like the musculocutaneous nerve, which goes to the biceps normally, you leave it with biceps. It will continue farther on into the arm if you're doing a transhumeral, for example, and be the lateral antebrachial cutaneous. You will cut that, that's a sensory nerve, and that you can bury, but you're going to keep the musculocutaneous where it's attaching to the biceps. And it can be used. The biceps normally will be elbow flexion. You can use that with myoprostheses and do it for elbow flexion. But then you have the median nerve, for example, the median nerve, which normally would be used for wrist flexion and digital flexion and closing. You can do something else with it. Median nerve is not going to do anything in the upper arm. You're going to cut it, but instead of just leaving it there, you can do a targeted muscle reinnervation to the short head of the biceps. So now you're splitting the muscle of the biceps, and now instead of doing what a two-headed muscle normally does in terms of elbow flexion and supination, now we have two muscles of the same doing two different things in a prosthesis. Similarly, you can see the ulnar nerve going to the brachialis for other hand wrist control, which the ulnar nerve normally does. We can have the proximal radial nerve going to the long head of the triceps for elbow extension, and the distal radial nerve can go to the lateral head of the triceps for hand opening. Again, what the radial nerve normally does. So having all these different nerves go to new muscles instead of the triceps just doing elbow extension, now you can split it, divide some of the nerve attachments, and reconstruct some of the nerve attachments. And now all of a sudden, up here, even without going into the chest, you have 5 different motions you can have an elbow, wrist, and hand do. Again, the orthotists, prosthetists know this better than we do, but as of right now, most of these are done with surface EMGs. So sometimes when you do these surgeries, you're going to smooth out and really take out a lot of the fat so that the skin is as close to the muscle as possible. You're going to map the muscles and see where the signals are, and that's where you're going to put your implants. So you're going to put your pickups right on the skin for a surface EMG to control it. This is advanced. This is new. This is in the e-Opera, the electrical, or however you want to call it, exciting, or however you want to go with this. This is really very, very new in that instead of using surface EMG, you use the Opera. It's transosseous, but you also then drill a hole through the bone above this, and you pass out some wires. You have wires with different kinds of connectors. You can put it directly onto muscle to pick up the muscle. If you have a nerve that isn't doing anything, you can put a cuff around the nerve. So when the nerve is stimulating, it will go to that wire right there. And then these signals can all be processed in the prosthesis, a little bit in the fixture, in the prosthesis, pick up all these signals, and then it can go directly to the prosthesis. So you're not worrying about surface EMGs anymore. You can see how this picture, this X-ray on the right, has a bunch of different leads and wires in different places on different nerves and on different muscles. This picture on the left, this Ewing amputation, is the agonist-antagonist myoneural interface. This is a different way of doing prosthesis without osseointegration. It's still going to be surfaced, but you can take muscles that normally go against each other, and for example, tib-ant and gastrocnemius, you can connect them over the top. You take a little bit of fascia from the tarsal tunnel and you connect them over the top. But these muscles are right here in the front and available. Those little yellow dots are little pieces of metal, I think tantalum, that you put in. So they're markers so that you can, again, kind of fix where these muscles are going to be. And these muscles should normally work against each other. That's why they're connected. When tib-ant pulls, lateral gastrocnemius is going to stretch. And that's how muscles should work. They want to continue working that way. And at the same time, you can do a surface pickup to be able to work on an electrical prosthesis for function. So now we're coming kind of to the end of our talk, and I wanted to introduce what we're doing at Northwell. For those of us who are part of Northwell or who work with Northwell, obviously, you know, we're quite big on Long Island. We are the biggest healthcare system, certainly in New York State, and I don't think they have any reason to get smaller. So we're going to continue getting bigger, and we're putting forward a new amputation program to take care of these patients. Again ahead of time, instead of one patient and trying to find, oh, can I get them to Dr. Rusty? Oh, they're in Manhattan. Oh, who am I going to get them to for prehab? Have this all set up ahead of time. So the minute Dr. Kanan says this patient has a sarcoma, unfortunately their limb is not salvageable. However, I want their best reconstruction for the best function. Boom, we have a program that we are going to plug them into, that everything is going to be available to these patients. So, as I said, provide integrated care across specialties who may potentially undergo amputation. And then for Dr. Aresti, who says, you know, I have this patient who I see every once in a while. I really think that they need more than they're getting. They may not even know it. I want to make sure they know what's available to them. So someone who had an amputation for 15 years but can do better, Dr. Aresti can plug in to the program and have all of us available, whether it's for another surgery for a neuroma, or for an OPRA, or for social work to be able to work with them for prosthesis, or for having a support group. So again, optimized care, achieve highest level of function and mobility for the patients. As I'll say shortly, this is only done when all of us are working together and on the same team. Patient education and create a support group specific to this patient population. Northwell definitely has support groups for patients with amputations, but there's nothing for this group. And having this group be identified, certainly important to talk to other patients who have had amputations. But again, a 75-year-old who had a diabetic amputation in their midfoot is very, very different than a 32-year-old who had a sarcoma and who now has a transtibial amputation. So again, refining our patient pathway for all the specialties involved. And this is kind of how we envisioned our patient-centered care. Patient goes in the middle. They have access through the program to everyone, whether it's our surgery group. I don't know who put us on top. It just happened. It wasn't me, I promise. And physical therapy on the bottom certainly was not important. That was not something we meant to do. I'm sorry, Bill. But you can see all the different groups who we have here for orthotics, cancer rehab. Dr. Aresti. Dr. Aresti is actually not a cancer rehab doctor. He is a regular physiatrist, not regular, but he's a physiatrist that actually doesn't do as much cancer. We have a group of 4 cancer rehab specialists who will work with amputations and with Dr. Rusty. However, they specifically are used to taking care of these cancer prehab and cancer patients for those that are different. Working with behavioral health, I strongly believe that patients should be offered this preoperatively. We didn't have someone talking today. However, I believe that having a therapist work with these patients is really important, because this is a loss in the patient's life. So grief counseling to help them through that loss is something that I'm never going to be able to do well as a surgeon. I will be able to do targeted muscle reinnervation. I will be able to get as good a residual limb as hopefully possible as anyone else can, and our team can do, but I will not be able to support them what they need there, and that's why we have professionals in behavioral health from Northwell who again have interests in this. Social work is so important to be able to get everything. So we do have Northwell credentialed orthotists and prosthetists, but we work with everyone who wants to work with our patients or who our patients are already working with, and who can all work together. So that's kind of where we are right now. The really high level view and mission statement of this is that best outcomes are from a combined team approach. That's why we did this for Sarcoma Awareness Month, and that's why we did this to get everyone together. I'm amazed everyone, I think we lost about 5 people along the way. I'm so happy everyone stayed together. I know that I'm only as good as the people who take care of my patients. So that's the therapists, orthotists, prosthetists, and everyone else in that circle who we just had. So better patient function, happiness. That's what we're all here for. So you have between ChatGPT and a couple of different ideas. We haven't named our program yet, whether it's going to be Northwell Reach because everyone needs to have an acronym, or Next Step, or Limwell, something like that. We're coming close to coming for a name for our new program. This is the phone number in order to get your patients involved with us. We have all of the pieces together, and that means all the subspecialties and all of the disciplines are ready to be involved. We're putting this together. I think it's going to make a difference for amputation care, certainly on Long Island. And we're really happy that it's there. So here at the bottom again is that great code. We're going to open this up to the rest of the questions now. So you can scan the QR code, and you need that 96829 activity code for your education. Someone said, "How can I get involved with this program?" Thank you for asking that. You can email Alexa, who was the host and our amazing organizer for this program. While she wasn't speaking, she was controlling everything the whole time and making sure all of us knew what we were doing with the computers and making sure this PowerPoint worked together and all the invitations and have everything. So first of all, thank you to Alexa Bernardini, who is one of our program managers in orthopedics, and everyone else who helped with this. In terms of how to do that, first off, you can reply to the invitation, and Alexa can get on that. There's that phone number that was in there that we can certainly get people involved with, and we would love to. Here's that phone number. Orthopedic Oncology is our group, which is able to start as a touch point for our patients, but we will, as the program develops and matures, we will have a great way to get anyone who wants to be involved, and also a great way for your patients to contact us and be in touch with us. So it's a couple minutes to 8. I think our goals were really nicely taken care of, not just completed, but elegantly brought to everyone. I hope our audience really was able to learn a little bit here. If there are any other questions, there's both the Q&A tab and there's the chat tab, and I'm happy to answer everything. I want to thank again Alexa for putting everything together, Dr. Kanan, Dr. Nolan, Dr. Aresti, and Mr. Kels for spending their time here tonight, and for everyone who came to learn a little bit. So thank you guys again. Doesn't look like there are any other questions right now. So thank you again. I hope everyone has a great night. And again, any questions along the way with these kind of patients, all of us are available to help out. Thank you.
And also, just to add, I'd like to thank everyone, Alexa and Dr. Goodman, for organizing this event. He kind of had this idea early on and gathered all of us, and we couldn't have done it without him. So thanks, Dr. Goodman.
Happy Sarcoma Awareness Month, I guess. July is almost over, but the more we know for this orphan disease, the more we can all take care of it. Thank you, everybody. Have a great night. Thank you, guys.